I guess we'll give it a second. People to show. All right, we'll get going. All right, this is a 29-year-old obese patient with complete heart block following ASD repair. How could you improve or optimize the pacemaker settings? So this is a download from the remote pacemaker report from the patient from 5 years ago. So anybody have any thoughts based on this, if there's any way that we could improve the pacing settings for this individual? Anyone care to give it a shot?
I can take a chance. Um,
Great.
I'm just looking here. It looks like the pacemaker is set to DDD, and this is a patient um, who presumably had. Was this patient pacemaker put in later in life or earlier? The reason I ask is I'm trying to get a sense of if we truly need AV synchrony.
I mean, why would we not need AV synchrony?
If like the patient had like congenital heart block or really early onset heart block, in which case they've gone most of their life living without it. But in this patient, presumably this ASD was repaired later in life, and they would benefit from AV synchrony and just overall
Saying a
well-being.
benefit, what are you speaking of?
Just how the patients like tolerate it.
You mean tolerate it? You mean like whether they feel it or? So
Yeah,
you're right.
or
You're
they feel
right.
well.
Go ahead. I'm sorry to interrupt you. I
Oh
apologize.
no, it's okay. Yeah, like if I feel like anecdotally I've heard that patients may not enjoy losing AV synchrony when they've lived their whole life having it, whereas patients who've never had it are more tolerant to just say a pacemaker that's set to VVI or something where it's just
Okay. So that's true that in general, people who are used to having AV dyssynchrony with single chamber V pacing generally don't mind it. And people who are used to having AV synchrony, older, like if, for example, any of us had sudden heart block, and somebody then put in a single chamber pacemaker, we would likely not enjoy that. And in fact, there's a name for that. It's an old-fashioned term, but it's still used, which is pacemaker syndrome, which is used to denote when you have VVI pacing and you have AV dyssynchrony and you feel canon A waves because the atrium and the ventricle are not in synchrony with one another. But the thing that's important to remember is that as a general rule, dual chamber pacing is usually better hemodynamically for everybody than single chamber. It's just that the difference is fairly minimal, particularly when you have normal function. So in a person who has normal ventricular function, the impact of having AV synchrony and dual chamber pacing is probably fairly small, probably in the range of 5 to 10%. So this is why in our very small patients and even in children throughout pediatric age range, it would be rare that there would be a very substantial improvement in cardiac output by achieving dual chamber pacing. And this is why whenever babies come up that have heart block, I'm always more than happy to tell the surgeon to just put a single chamber device in. A lot of younger cardiologists, I think, look at me like a dinosaur because I say that because they assume that dual chamber pacing is better, and it is better, but it is not so much better that it is necessarily equal in risk to the issues of having extra leads. We've talked in the past that epicardial leads can cause coronary artery strangulation later in life, so that, greater infection risk, greater complexity in general. In this patient, though, who's 29, let's assume that the patient needed a dual chamber pacemaker, has had it most of their life, and this is the settings. Is there anything or any data in this download that might suggest to you that there would be a way to optimize the pacing that is not presently being done?
Yes, I think that this looks like this patient is predominantly A-paced, V-paced, and I wonder if we can lower the threshold, the sensitivity on the atrial side to see if we can maybe A-sense more frequently and just V-pace and save some battery.
So is it the atrial sensitivity you would lower or something different that you would lower?
The, the threshold.
No, what's the threshold? I think you know the right answer. You're just using the wrong term.
Oh yeah,
So threshold, right, is a term used to denote how much energy is required to capture the myocardium. So that is not that's actually the only thing that we cannot easily assess in a remote check. It's probably the only thing that keeps me in business is that every once in a while it's useful to check the threshold. And you cannot do an easy threshold check. There is actually a poor man's threshold check that is done during a download, which we'll go over in a second. But what you mean is to lower the lower rate. Am I right, Blonde? Am I understanding what you're saying better?
yes, that's
So
not exactly
what does the lower rate mean? When it says lower rate 50, what does that mean?
that. If the native atrial rate goes below 50, then the pacemaker is going to A-pace.
That's right. But in a dual chamber pacemaker, the lower rate is actually refers to the ventricular rate. Always with dual chamber pacing, the the rate refers to the ventricular rate because ultimately that's what keeps you alive. And but if someone has normal sinus function, you're absolutely right. If the ventricular rate or the atrial rate were to fall below 50, it will start pacing the atrium and the ventricle. Um, so what we see here is that 78% of the time the patient is A-pace, V-paced. I mean, normally a person of this age, the, when they're asleep, they could certainly have atrial rates below 50, right? A normal resting adult could have heart rates even in the 40s. Now, if you're obese, it seems unlikely that's the case. And the lower rate isn't that high, it's 50. And so it is noteworthy that the patient is paced 78% of the time when set with a lower rate of 50. Can we say anything about the sinus node in this patient based on this?
No, other than it looks like it's being
Well,
sensed
I think
some
the
degree of time.
right, but I think it suggests the sinus node is impaired in some way, right? Because if I put an atrial pacemaker in you or me, I don't think we would be paced 78% of the time if the lower rate limit were set at 50. In other words, I think most of us, since none of us are extremely highly trained athletes at this time, I don't think most of us resting heart rates below 50 most of the time. And so it seems odd to me that the patient is being paced at 78% of the time. So it suggests that there is sinus node dysfunction. And
Dr. Pest might.
go
Oh,
ahead.
sorry. What I was trying to get at earlier is looking at this part of it. I was wondering if just the pacemaker's not sensing the native P waves, if the sensitivity was too high. I think that's what I was trying to say earlier.
I
That
see.
maybe
So
that
you're
it's
saying that the sensing is poor on the lead.
correct. And maybe
Ah,
that's why it's pacing so frequently on the atrium as well.
it's an excellent point, which I didn't even think of. But yes, that's certainly possible that the device. So how would you, if you were going to remotely assess this, is there any way you could do that?
I'm not sure about remotely, but I know in person you can bring them into clinic and interrogate the device and do a threshold testing and drop the sensitivity.
Yes. So you could tell how good the device is at sensing in the office, right? We could see, lower the lower rate below the atrial rate, intrinsic atrial rate, and see how it's sensing. So that's absolutely possible. So you're theorizing that maybe the reason the patient is pacing 78% of the time is because maybe the atrial rate is really 70 most of the time, but the device is undersensing it and is pacing, even though the patient doesn't need pacing. Am I understanding you right?
Correct. Yes.
Yeah, so that's possible. So I like that as a differential diagnosis of this issue. So that would be a reason. One thing you could do, though, is you could check older downloads. You would check two things. First of all, you could check the last in-office check to see what was the sensitivity set at. Was the sensing adequate? Were there any problems with sensing? What does the atrial electrogram look like? And actually, on present-day downloads, you can see the atrial electrogram. I'm not showing it to you in this example, but some pacemakers, particularly defibrillators, will definitely show you the presenting electrogram, and you can see the atrial electrogram. You remember last week we showed a case of somebody who was in atrial fibrillation, and you could tell that from the atrial electrogram. So you could see that. The other thing that would be interesting would be to see what percentage of, if you knew, for example, that 6 months earlier you did an in-office check and the atrial sensing was proper, and the last 5 downloads have all had atrial pacing ranges this high, that would suggest probably that there is not a problem with the lead, but maybe a problem with the patient's sinus node as well as with the patient's program. Maybe we could set the program lower. Now, if somebody's pacing 78% with a lower rate limit of 50, chances are that if you set it at 40, it's not going to go to 20%. Um, but there may be why would you lower it? What would be the benefit to the patient of lowering the low rate? So, okay, so you take the patient into the office, you check the sensing, the device is properly programmed, the atrial electrogram and the sensing is set properly, and you determine that yes, the device is appropriately pacing 78% of the time based on the patient's intrinsic atrial rate and the sensing of the lead. And you decide to set the lower rate, let's say at 40. Why would that benefit the patient? Or would there be no benefit to the patient?
Like lasting
Okay.
of the pacemaker more.
Say that again, Barty?
Like it can last longer.
Yeah,
Um,
exactly. You might, remember that when we look at pacemakers and battery longevity, pacing, I mean, it sounds kind of obvious, but for a pacemaker, pacing is the largest expenditure of energy. Sensing also uses energy, but much less energy. And so, yeah, if you could lower the percentage of paced beats, either in the atrium or the ventricle, you will extend the longevity of the device. And, it's interesting to note that studies have shown that, there've been a number of these studies where they look at adults at the time of death who have pacemakers. Something like 90% of adults, their pacemaker is programmed with the same settings that come out of the box from the company. And when they come out of the box, I believe the lower rate is 60 and the outputs are 3.5 volts and zero point 0.5 milliseconds for the atrial and ventricular leads. Isn't that interesting that the majority of people who implant pacemakers don't actually change the settings from the standard settings that the company sets? And so some of you who've been in cases with me have seen me ask the rep, what's the expected longevity of this device? And they're basing that on those settings out of the box, 3.5 volts and zero point 0.5 milliseconds. And they're basing it on 100% paced. And so most pacemakers today, they would say something in the range of 6 to 9 years. But of course, as you've seen, we're always looking for ways to tweak the program in order to try and squeeze the juice, as it were, out of the battery and get as much longevity as possible. So that would be another rationale for having a lower heart rate, or at least setting the lower rate. Because even if we could go from 78 to say 65, well, that could have a meaningful impact on the longevity of the device. It's not going to be a massive difference, but remember that over the course of a patient's entire life, they're going to need multiple generator changes. We've discussed how every time you do a generator change, the risk of infection becomes greater and greater. So it's really to the patient's benefit to have as few generator changes as possible and to have as much longevity per device as possible. Just this past week, we implanted a defibrillator, and we intentionally put the sort of in-between sized patient, but we decided to put the adult sized device in on the theory that, according to the manufacturer, that particular device had a estimated longevity of 14 years. And so I'm hopeful that if the patient does not actually use the defibrillator for either pacing or defibrillation, that the device will last substantially longer than that. So, all right. So I think we've squeezed as much out of this question as we can. Any questions about any of that? All right. Let's move forward.
Can Sorry,
Go
Dr.
ahead,
Pass.
Barty. Sorry.
What is the upper tracking rate and the upper sensor rate, if you can throw some
Very
light on
good
that?
question. Thank you for asking. So the upper tracking rate is how high will the pacemaker follow the atrial rate? So in other words, with this program of DDDR, if the atrial rate goes up as high as if it goes as high as uh, 180 beats per minute, the device will track it, meaning it will pace the ventricle in concert to the atrial rate up to 180 beats per minute. Now, interestingly, we maybe next week we'll go over this, but even though it says that the upper tracking rate is 180, if the post-ventricular atrial refractory period setting is too high, too long, and if the PR interval you've programmed or the AV delay is too long, then the patient may not actually track that high. So it's interesting. In the bedside pacemakers, you can actually set the tracking rate, and the device will automatically adjust the AV interval and the post-ventricular atrial refractory period to be able to track to that. But in a permanent pacemaker, it's the responsibility of the electrophysiologist to calculate whether it will actually track that high. Because even though the device will allow us to program it that, if the math doesn't work, it won't track that high. The sensor rate refers to the R in the mode. So Barty, what does the R stand for? Why does it say DDDR?
Responsive, like mm,
So what does that mean?
means if the ventricle rate means if the body's own rhythm is high, maybe it will not pace, like, or if the need is high, for example, if somebody's running, it will increase the heart rate, right?
So does it make sense that this particular patient has rate responsiveness on?
Oh yeah, not really.
No, actually, this is a good candidate for rate responsiveness,
Okay,
right? Because
okay,
remember, rate responsiveness means that the device has some sort of a sensor in it that determines activity, just as you said.
okay.
And as the activity increases, the device will slowly raise the lower rate limit of the device. So when it says the lower rate is 50, you're basically telling the pacemaker, never let the patient's heart rate go below 50. However, because the R feature is on, the fourth letter is on, the device will slowly increase the lower rate limit up to the upper sensor rate, which is 140. So in other words, if the patient starts running a marathon and is really pushing themselves, or is playing soccer and is stopping and starting, and this device senses the activity, it will slowly raise the lower rate as high as 140. Now, interestingly enough, studies have shown that the sensors in most of these devices are very poor, and they don't actually detect motion very well. Most patients, only it only goes up maybe 10 or 20 beats per minute. The other interesting thing is you can adjust the degree of sensitivity that the device has to activity, and you can make it a little more or less sensitive. And patients are exquisitely sensitive to that if they have been paced in a certain manner their whole life. Number of years ago, one of my adult congenital patients who I had taken care of since he was a 3-year-old had a dual chamber defibrillator in his abdomen, and he always had rate responsiveness on, and he always felt fine. When he turned about 25, we upgraded him to a dual chamber transvenous system, placed typically through his left shoulder. And I reprogrammed the new device exactly the same way that the old device was. And I did that intentionally because I'm aware that patients are very sensitive to minor changes in their rate responsiveness. And he could not stand it. He complained vehemently that he felt every time he drove, he said his heart was racing and he couldn't, he actually had to come in urgently one day to have me adjust it. And what I came to realize was that the degree of sensitivity was the device was picking up much more activity in his shoulder than it was in his abdomen. And as soon as I turned off the rate responsive feature, he felt profoundly better. Um, so that's what the rate responsiveness is. So rate responsiveness is a very important feature for someone who has sinus node dysfunction. Um, but interestingly, in this, so you would think that someone who is paced 78% of the time when their lower rate limit is set at 50 almost certainly does have sinus node dysfunction. So I would argue that based on what we're seeing here, probably it was the right idea to put the rate responsive feature on to get a more physiologic heart rate. But it is unusual. It's actually interesting, right? If we look at the percentage of beats that are paced versus sensed, we see that still the vast majority of his pacing is less than 60 beats per minute, despite the fact that the rate responsive feature is on. So even with rate responsiveness on, he really isn't pacing in the atrium much above 60. These are all, if you add all of this together, it's probably, 10% of all his pacing is above 60. So that gives you an indication of two things. One, that he's probably a fairly sedentary person, and two, that the rate responsive sensitivity on the device is very poor. There are different ways that pacemakers can detect activity. Medtronic devices, which this seems to be, have a piezoelectric crystal that can feel activity in motion and will slowly increase it. Some devices can use body wall impedance changes. Some of them actually have temperature probes on the lead that can assess small changes in body temperature as a way of increasing the heart rate. To my knowledge, I don't think any one particular mechanism of assessing activity is any more sensitive or better than another. And you can adjust it initially. So, probably if somebody normally had normal heart rate, normal variability, and as an adult developed heart block, that might be a case where you would adjust the rate responsive feature. But as a general rule, I usually leave it at the company setting. That might not be the right thing to do, but that's what I normally do. Any other questions about this? Okay, let's move on. This is a 15-year-old who had a VF arrest, and this is the electrocardiogram following defibrillation. So let me ask Dr. Gaudig if she has any thoughts about what this might be.
Good morning.
Hey, how are you?
Good, thank you. So let me see. I see upright P waves in 1-2 AVF. So it looks like this patient is in sinus node.
Sinus rhythm, agreed.
Yeah, sorry, sinus rhythm. I do see in the anterior leads the T wave morphology, or the QRS complexes look a little bit abnormal to me. So I'm not sure if that's like a,
So what do you make of lead V1 and V2? Does that anything catch your eye there?
sorry. I don't know. The ST morphology looks abnormal. Maybe it's like a Brugada type
Yeah,
pattern.
that's
But
right. That is a Brugada pattern. This is a so-called type 1 Brugada pattern with this very tall R wave and the down-sloping T wave, QRS down to the T wave or ST segment, I should say, S wave and ST segment. So when you see this like this is a very classic example of somebody who has Brugada syndrome. Um, Interestingly, there is a percentage of healthy, normal patients who have this pattern and do not have Brugada syndrome, but certainly if somebody just had a VF arrest and were defibrillated and this were the tracing you saw afterwards, would be very, very suspicious for Brugada. And on most of the Brugada diagnosis scales, I think having this pattern gives you enough points that you basically have at least a moderate chance of having Brugada just from this. This is a type 1, I think they call it the coved pattern, which is the most common and the most diagnostic. And if somebody, unfortunately in 2025, there aren't many medical therapies for Brugada syndrome. So someone who had a VF arrest and then had this finding on their electrocardiogram, the treatment of choice would be implantation of a defibrillator for protection of this patient. As well as anyone know what the triggers of what the most common trigger of VF in a Brugada patient would be?
I'm not entirely sure. But I think I read that there's an association sometimes with patients when they have fever that you see it more.
Yes, that's exactly right. So fever is the most common. And so one of the sort of pillars of treatment of or paradigms of treatment of Brugada is to remind all patients with Brugada to aggressively treat all fevers. So I will often tell families of children with Brugada, as pediatricians, we're taught to sort of use the fever curve as an indication of what is going on with a child. And so sometimes pediatricians will say, follow the fever. If it goes over 101, give me a call, or don't give Tylenol unless it's above 38 Celsius. But I recommend to families to break that rule when they have a child who has possible Brugada syndrome, which is to aggressively treat the fever. So I'll usually suggest to the families of people with Brugada that they have a functional thermometer in the house, that they know how to use it, and that if they see any fever at all, that they should immediately give Tylenol or Motrin and repeat the temperature in 30 to 60 minutes to confirm that the therapy is efficacious. And if not, then to add a different agent. If given Motrin, then give Tylenol or vice versa, because we do know that fever is a potent trigger of Brugada pattern and ventricular arrhythmias in this setting. And when I have patients in whom the diagnosis is challenging and we're not sure, I will often ask them that if the family is aware that the child is having a fever, if they can possibly get themselves somewhere where they can get a 12-lead EKG, it would be very helpful diagnostically. So I will often, some pediatricians offer EKGs in their office, or if they live close to the cardiology center, I'll tell them to just come in, no appointment needed to get an EKG if the child's having a fever, if there is a question as to what the diagnosis might be. Okay. Any questions about any of this? All right. I think if not, I'm going to stop. Yeah,
Could
go
I
ahead,
answer a
Mohammed.
question?
Sure.
In patients who had Brugada, is it every time they get a fever, they get this pattern, or sometimes they might not get the
No,
pattern?
they don't get this pattern every time. I mean, we really are, it highlights how rudimentary we are in this diagnosis. There is genetic testing for Brugada syndrome, but I think in the present era, it only identifies a small percentage of patients who have Brugada. So if it's positive, it's very useful. If it's negative, it is unfortunately not particularly useful. But fever is probably next to a sodium channel blocking agent like agmaline or procainamide. Probably fever is probably even a better mechanism for bringing out this pattern. So, and as we've discussed in the past, agmaline, which I am told is a particularly good agent for provocative testing of Brugada, is not available in the United States. And procainamide, although we do it, is a very weak one. So fever, I think, in the US at least, is a better way of bringing out this pattern. So if someone has a fever, and we're not sure of the diagnosis, I will often ask them to try to make it to somewhere where they can get a 12 lead. Thanks. All right. I hope everyone has a wonderful day. Speak to you later.